All right, so thank you all for joining us today for a very special talk and a very special guest. So Dr. Carol Oladele is an assistant professor in the section of General Internal Medicine and is the director of research at the Equity Research and Innovation Center at the Yale School of Medicine. She got her PhD in epidemiology from the University of South Florida. Her research focuses on social determinants of cardiovascular health disparities with a specific focus on the role of nutrition, healthcare quality, food, and the built environment. She has expertise in the development of dietary assessment methodologies for African descent populations. Her research aims to generate evidence to support health policies and interventions to improve cardiovascular outcomes among racial, ethnic, and immigrant populations, both domestically and globally. Her current work examines the role of food insecurity in ultra-processed foods on disparities in hypertension incidence and control. Thank you so much, Carol, for coming down. I'm looking forward to your talk. Thank you so much.
Thank you so much. Thank you so much for that introduction, Sadia, and thank you to the leadership, faculty, and staff of the Georgia Center for Diabetes Translation for having me here today. So the title of my talk is Achieving Nutrition Equity for Improved Cardiovascular Health. I have no disclosures for this talk. So today I'll begin by defining nutrition equity and linking and illustrating the link with food insecurity. I'll move on to talk about the burden of food insecurity and then the health impact of food insecurity. And here I'll highlight some examples from my work in the Caribbean, focused on food insecurity and hypertension, and from other work that leverages US cohort data. I'll then go on to talk about current solutions and gaps and opportunities for the development of new solutions. And I'll wrap up with implications and future directions. So nutrition equity is defined as access to nutritious and culturally appropriate foods, regardless of race, religion, gender, employment, or ability, or community. And this is important because we know that poor nutrition is a leading cause of illness. About 600,000 people die from diet-related diseases annually here in the US. 85% of healthcare spending is related to diet-related chronic diseases. And we know that there's a disproportionate impact on marginalized and minoritized populations. And there's also a disproportionate impact on those with high food insecurity. And those with high food insecurity and minoritized and marginalized populations, there's a big overlap there. So it's important to talk about high food insecurity. So what is food insecurity? Well, the World Health Organization defines food insecurity as a situation that exists when all people at all times have physical, social, and economic access to sufficient, safe, and nutritious food that meets their dietary needs and food preferences for an active, healthy lifestyle. And food security is connected to the United Nations Sustainable Development Goals, specifically Sustainable Development Goal 2, which is to end hunger, achieve food security, and improve nutrition and promote sustainable agriculture. So let's talk a bit about the link between nutrition equity and food security. So in order to achieve nutrition equity, you have to have food security, and there has to be equity, right? Equity in access to food, availability to food, access quality food, and affordability of food. And so once we have equity in food security, that will contribute to us achieving nutrition equity. And we know it's important to achieve nutrition equity because of its link with chronic disease outcomes. So if we're able to achieve nutrition equity, we can have reduced diet-related diseases and disparities. So specifically diabetes, hypertension, obesity, which are leading causes of death and all conditions that contribute to cardiovascular outcomes. And in talking about equity here, right, it's important to acknowledge the structures, right, that contribute to inequities in food insecurity, right, and inequities in access, availability, quality, and affordability. And structural racism is a main root cause of disparities in food insecurity. So thinking about policies, employment, transportation, if thinking about sort of structures that are designed in a way that allows inequities and disparities to persist. So next I'll talk about the burden of food insecurity, and I'll talk about the burden globally and in the United States and in the Caribbean where most of my work is focused. So food insecurity, again, it's defined as when all people at all times have physical, social, and economic access to sufficient, safe, and nutritious food that meets their preferences and dietary needs for an active and healthy lifestyle. So globally, it affects about 2.4 billion people in the US. 13% of households are food insecure, and in the Caribbean, where again, much of my work is focused, 61% of Caribbean households are affected by food insecurity. Given the global burden, there are international, regional, and national efforts to address food insecurity. One of the Food and Agricultural Organization of the United Nations, the Sustainable Development Goals, which I mentioned a slide or two ago, focuses on addressing food insecurity. The Biden-Harris administration, their plan that was laid out in 2022 to address food insecurity and disparities in diet-related conditions. So there are many drivers of food insecurity, and this slide highlights three main ones, thinking more globally. Conflict and civil unrest is one, climate and economic shocks. The results of these drivers is displacement of populations, decreased food production, and unaffordable foods. So I can't talk about food insecurity and sort of nutrition equity without highlighting the role of the COVID-19 pandemic in exacerbating food insecurity globally. The COVID-19 pandemic exacerbated it across the globe with its sharpest increases seen in moderate and severe food insecurity in Latin America and the Caribbean and in West Africa. Evidence also showed that the gender gap in food insecurity widened. So when we look at the distribution of food insecurity across the globe, we see that the concentration and distribution of food insecurity varies. These concentric circles show total population count in green, yellow shows the count of moderate or severe food insecurity, and the red color shows the count for severe food insecurity. And as you can see, what we can take away from the figure is that the relative impact of food insecurity is different, and it varies across these regions. And if we look at Latin America and the Caribbean, you can see that the red concentric circle is quite large compared to the overall sort of total population, signifying that the burden there is really high. When we take a deeper look, when we try to unpack Latin America and the Caribbean, so they're often combined together in like many reports, statistics, but when we sort of tease them apart, we see important differences between Latin America and Caribbean countries. So overall, if you look at overall estimate for food insecurity in Latin America and the Caribbean, it's about 37% or 38%. However, when we pull them apart, we see that it's 61% in the Caribbean and about 36% in Latin America. So important to distinguish and to, sometimes in looking regionally at food insecurity or other exposures or outcomes, it's really important to unpack it to see your masking disparities. A main factor that contributes to the high prevalence of food insecurity in the Caribbean is the high rate of food importation. And so, this graph shows the proportion of food consumed that's imported across many islands of the Caribbean. And so the yellow line is at 50%. And as you can see, the majority of countries, right, like import the majority of, like over 50% of the food that they consume. And having a higher rate of imported food leads to higher cost of foods, right? Because it costs more to import food. Making food, and especially healthier foods, unaffordable to many populations across the region. In US context, food insecurity affects about 13% of households. When we look at households with children, prevalence is even higher at 17%. Low food insecurities, about 8% of households are affected, and about 5% of households are affected by very low food security. This graph shows responses to the current population survey, food security supplement items. And here I want to highlight responses among those who indicated being very low, having very low food security. So 98% of those households worried their food would run out before they had money to buy more. 97% of those households reported that the food they bought just didn't last and they did not have money to get more. 96% reported that they could not afford to eat a balanced diet. Yet this is the message. And if you're someone living with a chronic condition, I'm sure when people go to the doctor, that is what they hear, like balanced diet. However, we have there are households across the US that just aren't able to make that happen. So in addition to the overall burden of food insecurity in the US, there are also disparities across demographic groups. So we know that food insecurity is more likely to happen in woman-headed households compared to men. We know that people who have lower socioeconomic position are more likely to experience food insecurity. Households with lower income to poverty ratio and rural households are more likely to experience food insecurity. We also know that there are persistent racial and ethnic disparities in experiences of food insecurity. The rate for Black and Hispanic households is more than double that of white households in the United States. I'm going to move on to talk about the health impact of food insecurity and provide a few examples from some of our work in the Caribbean region. So before we talk about the health impact, I thought we would review conceptually sort of how food insecurity, mechanisms by which food insecurity impacts health. So this conceptual model shows how dietary quality is a main pathway through which food insecurity impacts health. So food insecurity can lead to constrained dietary options that lead individuals to develop coping mechanisms that increase risk for the development of diseases and for management. So those coping mechanisms may be to eat more calorie-dense foods that sort of last longer, or to purchase foods that have long shelf life. They won't go bad. They'll last a long time, or foods that will be enough. Maybe not nutrient dense, but that would feed a family. There's also, it's also possible for food insecurity to come as a result of diagnosis with a chronic condition, right? So you can be diagnosed with a chronic condition. If we look at the blue box below, where it says obesity, hypertension, diabetes, that could lead you to have competing demands, right? Maybe now you have to buy medicines and buy food, and maybe there's, you have to make a choice there. That could also lead to sort of, competing demands where you're in a cycle where you're experiencing food insecurity as a result of a diagnosis. So in talking about relationships, I want to acknowledge the multi-level influences that contribute to food insecurity and poor health. So these structural, community, and household level influences play a key role in the relationship between food insecurity and health outcomes. So, socioeconomic and environmental factors, So we looked at structural factors, so food market prices, income inequality, structural racism, climate change, at the community level, food deserts and food swamps. So food deserts are places that don't have adequate supermarkets and other like proper establishments to purchase foods, and are places that are oftentimes, and swamps are oftentimes places that are filled with corner stores and lots of fast food places. Unaffordable housing is a community level factor that influences safety net resources. At the household and individual level, lack of social support, financial instability, stress, anxiety, and then other characteristics like age, sex, and education. So there's lots of evidence that show that food insecurity is associated with myriad health outcomes, which are also characterized by racial and ethnic disparities. Food insecurity is associated with a number of health outcomes and is more prevalent in adults with existing cardiometabolic conditions. And so for the rest of the talk and for the examples that I'll present today, they'll focus on diabetes and hypertension, which are two outcomes that I investigate in my research. So looking briefly at the literature on food insecurity and diabetes and hypertension, we know that there's a higher prevalence among households and individuals who have these chronic conditions. We know that food insecurity is associated with poor management of these conditions. And we know that there's a disproportionate impact on marginalized and minoritized groups, and that food insecurity increases risk of cardiovascular morbidity and mortality. So in the Eastern Caribbean, there's high burden of food insecurity and non-communicable diseases, so most of which are related to diet-related risk factors. Cardiovascular disease is the leading cause of death in the Caribbean and a major source of morbidity. Yet there's limited surveillance on key driving risk factors like diabetes and hypertension, and there's little evidence on the role that food insecurity plays in health. So given the prevalence of food insecurity in the region, links to negative health outcomes, and a paucity of evidence in the region, we sought to examine the relationship between food insecurity and the care cascade for diabetes and hypertension. So much of my work leverages data from a 4-island cohort called the Eastern Caribbean Health Outcomes Research Network cohort study. So this is again a 4-island cohort, the coordinating centers at Yale University. And it's a collaboration between 4 institutions across the Caribbean. So the University of Puerto Rico, the University of the West Indies in Barbados, the University of the West Indies in Trinidad and Tobago, and the University of the Virgin Islands. And the goal is to establish a regional infrastructure to generate action-oriented research with a focus on chronic disease through engaging communities to reduce the burden and high-burden chronic diseases in the region. So the 3 aims are: 1, to develop a research infrastructure focused on chronic diseases. That's the cohort study. The second aim was to recruit and follow a cohort. And then the third aim is to build capacity for regional health outcomes research, policy, and community engaged leadership. So in order to participate in the cohort study, eligible participants had to be English or Spanish speaking, 40 years of age or older, able to provide informed consent. They had to have had reliable residential information and no plans to relocate in the next 5 years. And so baseline data was collected between 2013 and 2018, and participants completed a self-administered questionnaire about their health. They underwent a brief physical exam that allowed us to get clinical data. And also there was an option to provide biological samples for future work. So our study took a cross-sectional analysis to look at the relationship between food insecurity and diabetes and hypertension. We used baseline data from the cohort, and we included participants if they had complete data on food insecurity, diabetes, and hypertension. Our main outcome was food insecurity, which was measured using the ALSA scale. So this is the Latin American and Caribbean Food Security Scale. And the house code, it ranges from 0 to 9. So, 0 is you're food secure, 1 to 3 means you have mild food insecurity, moderate 4 to 6, and severe food insecurity score 7 to 9. And so here are some of the questions. So the scale asks, during the last 3 months, because of lack of money or other resources, were you worried about running out of food? So it asks, anywhere from that to, the last 2 questions are, was there a day when you or another adult didn't eat once? And then the 9th question, did you do things like begging or sending children to work to get food? Our outcomes were measured in a variety of ways. So we measured diabetes using self-report or A1C or fasting glucose values. So if they had an A1C value greater than or equal to 6.5 or fasting glucose greater than 126. Awareness was defined by self-report. So if they said they had an elevated A1C or fasting glucose, and they self-reported, yes, then they were aware. If not, they were unaware. Control was defined as having an A1C level less than 6.5 or fasting glucose less than 126. And we created binary outcomes for use in the analysis. So yes, you had control or diabetes. Yes, no for like awareness, control, and prevalence. Hypertension similarly was defined using self-report and data from our clinical exam. So the self-reported question was a question that you typically see on like the BRFSS or NHANES or other surveys. Has a doctor or other health professional ever told you that you have high blood pressure? And so blood pressure values greater than or equal to 140/90 was used to define hypertension. And this is based on JNC 7 guidelines because that was the time, those were the guidelines in effect when the data were collected. Awareness was defined by self-report. Control was defined as having a blood pressure less than 140/90. And again, we created a binary category for use for analyses. We evaluated these covariates in a lot of our analyses. And for analysis, we used analysis of variance, chi-square tests, and multiple logistic regression. So a few demographic characteristics for the cohort. The mean age is 57, 63, most were women, 63%, 54% had were high school graduates or lower, and 85% had a usual source of care. In looking at food insecurity prevalence, we see that about 27% of the cohort experienced some level of food insecurity. And just for comparison purposes, like the overall prevalence in the United States is about 12%. Consistent with much of the food insecurity evidence, we found that women were more likely to experience food insecurity and those with less than a high school education. We also saw that there was variation in food insecurity across sites, across our study sites, with Trinidad and Tobago and Puerto Rico experiencing more food insecurity compared to the US Virgin Islands and Barbados. There was also no difference in usual source of care by food insecurity level. When looking at diabetes, prevalence was about 28%, and among those with diabetes, 23% were unaware. And among those who were aware, 69% lacked control. When we look at diabetes, when we look at prevalence, lack of awareness and lack of control, we see here the green bars represent lack of control. And I think that the two striking things stand out. Like one, overall, there's just poor control. Anywhere from like 68% to 85% of participants lack control. And then if we look at those who experience moderate food insecurity, 71% lack control. And among those with severe food insecurity, 85% lack control. So looking at prevalence of diabetes, we can see that severe food insecurity, about 27% experience severe food insecurity, about 28% of people with moderate food insecurity have diabetes. Lack of awareness, again, about 35% among those in the severe category. And we look at lack of control, again, it's about 86%, 85% among those with severe food insecurity. When we looked at our multivariable analysis, so these models are adjusted for age, sex, site, education, and usual source of care. We didn't see any significant findings for diabetes prevalence. So there's no relationship between food insecurity and diabetes prevalence. And again, this is a cross-sectional look, right? So we're unable to actually like look forward, at least so far. Hopefully some future work we'll be able to do that, but cross-sectionally, there's no relationship there. When we look at food insecurity and diabetes among women specifically, we see that women with moderate or severe food insecurity have 1.63 times greater odds of diabetes compared to women who are food secure. So that was a significant finding. And this is, the majority of the literature shows that women experience food insecurity more and they're more likely to be negatively impacted in terms of their health. So this finding is consistent with the larger body of literature. We didn't find significant results for lack of awareness with diabetes or lack of control among women. When we look at men, the results for men showed statistically significant results for a lack of awareness and showed that men were more likely to be aware of their diabetes status compared to men who were food secure. Switching over to hypertension now, and looking at trying to understand prevalence, awareness, and control, we see that about 63% of our cohort has hypertension, 21% lack control, and about 21% lack awareness, and about 57% lack control. Those who live, looking at hypertension, the hypertension care cascade by level of food insecurity, we see that those who live in households with moderate or severe food insecurity are more likely to be aware than those with mild food insecurity or those who are food secure. 70% of those with severe food insecurity did not have their hypertension. So that was a pretty striking finding for us. We did our multivariable analyses to look at a relationship between food insecurity and hypertension. We see that none of these results are significant, right? So no significant finding between food insecurity and hypertension. We do see a distinct pattern for men compared to women, right? We see this like increasing dose response relationship, though not significant for women, and we see the opposite for men. In looking at awareness, again, findings weren't statistically significant. However, results suggest that individuals with moderate or severe food insecurity are more aware. And again, some of when we get into like the moderate and severe food insecurity categories, like the numbers get small. So, though not significant, those patterns I think are still very telling and sort of track with the patterns that we see in looking at findings from the US and other countries. When we look at food insecurity and hypertension control, multivariable models there, we see borderline significant findings for moderate and severe food insecurity and hypertension. So we see that the odds ratio for women with moderate food insecurity was 1.8 and 2.27 for severe food insecurity. So, the lack of control is increased with more severe experiences with food insecurity. So in addition to investigating relationships between food insecurity, diabetes, and hypertension, we wanted to examine the impact of food insecurity on dietary quality in the cohort. As I mentioned earlier, we talked about the conceptual model, and dietary quality is the main pathway through which food insecurity impacts these two conditions. So we looked at food insecurity and fruit and vegetable consumption and consumption of sugary beverages. And as expected, our findings showed decreased consumption of fruits and vegetables, lower consumption with increased severity of food insecurity. And we saw the opposite for sugary beverage consumption, where consumption increased with increasing severity of food insecurity. We know that food insecurity is associated with dietary quality. We just saw that it's associated with lower consumption of fresh fruits and vegetables and higher consumption of sugary beverages. We know that there's an increase in consumption of sort of cheap, nutrient poor, calorie dense foods, and foods that we consider ultra processed too. So we wanted to examine that. However, data in the Caribbean is limited around ultra processed food. So we leveraged data from a US based cohort to examine this association. So, how is ultra processed food consumption related to hypertension? So we leveraged data from the REGARDS cohort study, and the goal of the REGARDS study is to elucidate factors that contribute to racial and geographic differences in stroke mortality. So what are ultra processed foods? So they're formulations of many ingredients, mostly industrial use that start from a sequence of industrial processes, hence why they're called ultra processed, because they undergo a sequence of industrial processes. And the main purpose is to create highly profitable food and drink products. So low cost ingredients, things that have long shelf life, branded products, promoted by transnational corporations. So these are the processes included in the development of ultra processed foods. So foods that undergo these processes are considered ultra processed. And you probably don't. Well, I know when I started this line of work, I didn't recognize any of these terms, and I'm like, do I want to eat food that's like undergone these processes? But once they foods that undergo, this is what makes them ultra processed. So, big picture findings from our REGARDS investigation, we found that ultra processed food consumption was associated with 33% higher odds of incident hypertension. We saw that there was a greater negative impact of ultra processed food among Black adults compared to white adults. And we found that ultra processed food was not associated with diabetes in this first look. So just to summarize the findings from ECHORN and REGARDS. So in the Caribbean, we know that there's a high burden of food insecurity in the region. Diabetes and hypertension control are pressing health issues, with 69% lacking diabetes control and 57% lacking hypertension control. Women are more likely to experience food insecurity and experience negative health effects. Food insecurity is associated with lower fruit and vegetable consumption and higher sugary beverage consumption. And we know that ultra-processed food is implicated in the development of hypertension. So I'm going to highlight briefly current solutions and opportunities or gaps that we could fill. So globally, the response to food insecurity is mainly falls in three buckets. One is like agricultural solutions, so building capacity among farmers, investing in agricultural technologies, and boosting crop production. Addressing water security is another solution, and then becoming more climate resilient. Structural solutions that currently exist, and most of these exist here in the US and not so much in the Caribbean, but we have federal social safety net programs, right, such as SNAP, WIC, National School Lunch Programs, Earned Income Credit, Child Tax Credit, and in some places, taxation of unhealthy foods. We also know that there's a sort of reemergence of universal basic income, or some people may know it as guaranteed basic income. And so this is consistent, unconditional payments distributed by the government to ensure a basic standard of living for every member of a community. And the goal is for it to address economic inequality and improve economic security. And so there's some evidence. So many of the studies that have been conducted are more like pilots. This is also not a new concept, right? GBI or UBI was tested like back in the, I think, 70s. So not new, but it's sort of coming back. But there's some evidence, a more recent evidence, to suggest benefit, based on these pilot and sort of smaller scale studies. They found, it could result in decreased hunger, improved well-being, decreased psychological stress, and improved child health outcomes. At the community level, solutions exist, community resources, so like food pantries, feeding programs, retail food environment interventions. Those might include, thinking about placement of foods within small food stores or even supermarkets, labeling of foods, labeling, calories, putting calories on menus, things like that. Community and school gardens, having green carts or farmers markets, transportation, and then healthcare system screening and referral to community organizations. Household and individual level solutions, their food prescription programs or food as medicine programs, and then healthy incentive programs, so getting like bonus cash to buy fruits and vegetables, or increase SNAP benefits, or doubling the money you have if you purchase certain items. So what do we know about the existing solutions that I just covered? Well, we know that, many of them exist, but we know that many of them have limitations on their impact. Current nutrition program aid amounts are inadequate to address food insecurity. Accessing nutrition programs is a complex process, and there's inconsistency in community organization funding and capacity. So for example, think about local pantries, right? They're all dependent on sort of community organizations that are already financially constrained and may not be able to consistently provide those resources. And then inequitable reach and sustainability of some of the existing solutions. And I want to highlight that for populations that experience health disparities and have complex social and structural realities, these solutions are even more limited. So a few key points here. There are solutions at multiple levels to address food insecurity. Opportunities to build upon existing interventions to improve reach and impact exist. And then there are also opportunities to scale solutions with high impact potential, such as like a GBI. So if these like small pilots are showing benefit, how can we think of a way to sort of scale that out and have like larger studies to demonstrate benefit on a larger scale? So the next few slides, I'll talk about implications and sort of future directions and leave you with a few things to sort of think about in thinking about food insecurity. So, as we think, I think a lot about populations that experience health disparities. So, how can we think about solutions, developing solutions and implementing them in a way that achieves nutrition equity? So, improving food environments, so having an equity lens when you think about sort of having food that's available, accessible, affordable, and structural things. So building a more resilient food supply chain that provides more and better market options for consumers and producers, while reducing the impact on climate, creating a fairer food system that combats market dominance and helps producers and consumers gain more power in the marketplace, creating new and more and better local market options, right? And so in trying to achieve nutrition equity, right, the ultimate answer is like, we need food system transformation to address food insecurity globally, which we connected to like, we need to have equity in food security in order to achieve nutrition equity. And so that will take multi-sectoral effort to get there. And we're not going to get there overnight. But I think if we have our eye towards sort of the target, which is food system transformation, and continue to sort of work on the solutions that we currently have to improve them and think about new ways that we can have solutions and ensure that they have a reach and impact for populations that are most affected. So the imbalance of, so to address social and economic determinants that drive food insecurity and disparities is definitely like, these are things that have to go hand in hand with other efforts to try to transform our food system. So addressing things like unemployment, like households are food insecure because it's rooted in an economic issue, and that economic issue, that economic inequality, right? The root cause of that is like systems and structures that cause these disparities and inequities to persist, including structural racism. So addressing things like unemployment, right? Inequalities in employment. We know that about 9% of Black adults are unemployed versus 8% of white adults. Address income inequalities. Black workers earn 24% less per hour compared to white workers. Implement initiatives that reduce poverty. So we know that populations of color, not just Black adults, are overrepresented in poverty. And then to addressing inequities in our quality of education. So, high poverty, under-resourced schools are mainly comprised of like Black and Hispanic students. Like these things are not happenstance, right? They're a result of historical and current structures. And so, how can we think about new solutions that disrupt those structures? So opportunities for future research to reduce food insecurity and advance health equity and advance nutrition equity, structural things, policies for front of package labels, looking at experiences of racism and nutrition safety net programs or other experiences, looking at the community or system level, doing community-led implementation interventions, like partnering with communities and letting them lead. And then screening for past experiences of food insecurity. because food insecurity is not as static, even though that's because of sort of how we measure food insecurity. We really capture it in a very static way, but it's not static. A household could be food insecure this month, and 3 months from now they're no longer, but in December they might be again. So, thinking of ways, is there a routine way, and what spaces do we sort of routinely screen for food insecurity? At the individual level, looking at mechanistic pathways, trying to understand mechanistic pathways between food insecurity and outcomes, and understanding experiences at different stages of the life course. Can that tell us something different? So just quickly, the FDA is now conducting consumer research to explore the development of front-of-package nutrition labeling schemes and plans to issue a proposed rule for public comment. And we know that Latin America really pioneered a lot of this work. Chile and other countries in South America really led the way with front-of-package labeling and demonstrated success. Understanding experiences with safety net programs. This is another area for potential sort of opportunity. We know that 55% of food insecure households participated in at least one of the 3 largest federal nutrition assistance programs. So that's still a large chunk of people, of households that are food insecure that are not participating in these programs. And the question is why? Is there room there to understand so that we can either get those households engaged or to understand something about the experience that would help to address food insecurity? Community guided implementation of evidence-based solutions. So, I'm a big proponent too of learning across borders. We can learn from others outside of this country front-of-package labeling is one really good example. Chile, Brazil, those countries really led the way, and I think there's lots of opportunity for bi-directional learning. But on the left here is an example of a community-led implementation program that we're doing at Yale. It's called the Community Health Equity Accelerator. And this is where we have a community coalition of community members who are guiding our research team in implementing an evidence-based solution to address pediatric asthma. So that's just one example of a structure that can do that. You can sub in whatever the pressing health issue is of the community, but using sort of this approach or model where community leads may also be a way for doing a little bit more of that to make some headway in addressing food insecurity and other pressing health issues. Screening for past food insecurity experiences is I think another opportunity for us. So this might be a way for us to identify people at risk. And also since we don't know, since we typically capture food insecurity in very static ways, for example, if I experienced food insecurity for many years as a child, do we know what the biological impact is on children at critical stages of development? And so it might be possible that asking about querying patients about or participants about past experiences may prove useful. And we know that there's little evidence on the impact of past or early experiences on metabolic risk. Individual level research areas, understanding experiences across the life course, and again, understanding mechanistic pathways between food insecurity and cardiovascular outcomes. Couple key points: structural solutions are needed to make significant improvement. We can definitely have bidirectional learning, and partnered research and initiatives hold promise in identifying effective and sustainable solutions. In summary, food insecurity is a serious public health challenge globally. Solutions must span multiple levels of influence. Progressive structural solutions are needed to see impactful change. And community partnered, identified, and implemented solutions are important to advance health equity, and illuminating experiences across the life course and with different experiences with different interventions offers an opportunity to refine existing structures and to promote. I'd just like to acknowledge my collaborators in a lot of this work and funding from NHLBI and IMHD. Thank you, and I'm happy to speak.